Actually, just about 10 years ago, there were relatively few treatment options compared to what we have today, which is, relative wealth of options.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Deb Sundi. Dr. Sundi is a James urologist who specializes in bladder cancer. The James is a leader in screening, diagnosing, and treating bladder cancer, and Deb will fill us in on the different types of bladder cancer, the symptoms, some of the advances in treatment, and his own research. Welcome to the podcast.
Thank you. Happy to be here.
Good. This is a topic we haven't got to before, and so I'm very curious to learn about bladder cancer. Let's kind of start with the basics. What is bladder cancer? And I understand there's a couple different kinds of bladder cancer.
Yeah, that's exactly right. So, it's worth talking about in just a couple sentences where the bladder is and what it does.
Yeah.
The bladder, of course, is the organ that stores urine for temporary periods of time before someone evacuates it from their body. It's located deep in the pelvis, and that urine, by the way, is produced a little bit higher up in the body from the kidneys, and the kidneys make that urine. The urine trickles down towards the bladder by way of these fairly delicate tubes called ureters. You have one ureter on each side of your body that goes to comes down from each kidney, empties into the bladder, and again the bladder is sort of that temporary dwelling space for urine. So bladder cancer. Bladder cancer arises from the innermost lining of the bladder, basically the layer of cells that makes contact with the fluid inside the bladder. That's where bladder cancers start.
So if I'm thinking of it almost as a balloon filled with water, or in this case urine, it's that inner side of the balloon, rubber, or in this case the inner side of the bladder wall.
That's exactly right. And just to qualify that with a little more detail, is that the balloon, in this case, is made up of a lot of different layers.
Okay.
And the layers are made up of blood vessels and collagen and nerves, just as an example, and muscle fibers, different types of muscle fibers. So it's a multi-layered balloon. We often cannot pin down for any given patient what the reason for their cancer was, but if you look at big data sets, some links become pretty clear. Number one, there is a genetic risk factor for having bladder cancer, and that genetic risk factor is being male.
Oh.
So being male or having an XY chromosome 23 instead of an XX chromosome 23 means there's a much higher risk of bladder cancer, about a four-fold higher risk. So that is why 75 to 80% of new cases occur in males, actually. So that's number one. The second, I would say, kind of basket of causes are environmental exposures. The number one environmental risk factor for bladder cancer is exposure to tobacco smoke and tobacco products.
Wow, I've never heard that. I know lung and heart, but also the bladder. Smoking can impact the bladder. Wow.
Yeah, it's a huge impact.
Yeah. Wow. So, okay, so those are two of the known causes, and I'm guessing that there's also some cases that women who don't smoke get it, so that it's unknown.
Yeah, that's true. So there are some cases, and by the way, bladder cancer is very common. So even though only 20 to 25% of cases occur in females, there are still a lot of females who will get bladder cancer, and there are people of all patients are at risk of getting it, even if, let's say, they haven't had any tobacco exposure in their lifetimes, or perhaps not had the industrial exposures to some of the aromatic chemicals that are also linked to bladder cancer. So there are certainly many cases where we don't know the cause. There are also a few cases where someone might have a strong family history of bladder cancer or other cancer, urothelial cancers of the urinary tract, where there might be known mutations that we can evaluate for here in cancer genetics at the James and kind of find these causes.
And what are the different types of bladder cancer?
That's a really important question for really anyone who has been diagnosed with bladder cancer, and frankly, the loved ones, their family and friends, helping them get through it. It's bladder cancer is kind of a catch-all term, but the treatment or management options that are recommended to someone are highly dependent on these nuances and different types of bladder cancer. So to break it down, kind of the major categories of bladder cancer, the first question to answer is, what is the stage? Is it localized? Is it contained within the bladder? Or is it metastatic? Has it spread to lymph nodes in the pelvis or other parts of the body or other organs? So is it localized or metastatic? That's kind of the first fork in the road. And in each of those categories, there's different subcategories that are really important that help determine treatment. So if something's localized in the bladder, which we hope it is, and most cases are, then we ask the question, is the tumor non-invasive or is it invasive? And that refers to whether a tumor is growing into the deep muscular scaffolding of the bladder. Remember, the bladder is a multi-layered organ. One of the layers is called the muscularis propria. That's the muscular layer of the bladder that actually squeezes when it's time to urinate. If a tumor invades into that muscular layer, we call it muscle invasive, stage T2 or T3 or T4.
Depending on the size?
Depending on actually the depth of invasion.
Okay.
And if a tumor has not yet breached that muscular layer, the muscularis propria, then we consider it non-invasive. So then the stage is TA or T1 or TIS, which stands for carcinoma in situ. So then once you have that sort of understanding, is it localized, is it metastatic, is it non-invasive, is it invasive, then there are even sort of sub-branches within that, and probably the most important, and I'll talk about non-invasive bladder cancers, because non-invasive localized bladder cancers comprise the vast majority of new diagnoses, about 80%. We then have to understand, we talked about the fact that there are a number of stages, TA, T1, in situ, and within some of those, within the TA stage, there's low grade and high grade, and that refers to whether the cell, when the pathologist looks at it under a microscope on an individual level, whether that cell looks aggressive or not. That's what high grade or low grade refers to. And all of these variables are really important because then they feed into, well, here are the treatment strategies that are likely to be successful.
Wow, it sounds like, and I hadn't thought of this, that you really need to be an expert to understand the type of bladder cancer in order to do the right treatment, and that a comprehensive cancer center connected to a large cancer hospital like the James will have the experts like you who can make those really precise diagnoses, which really impacts treatment and how people do with treatment.
Yeah, that's a good pickup. I'm glad you mentioned that. I think the truth is, you can tell already just thinking about the subtypes of bladder cancer. It's nuanced, and there are nuances beyond that. And so ultimately, I do think it benefits patients who are dealing with a bladder cancer diagnosis to have a consultation with someone who, essentially does this 24/7. It's nuanced, and I think talking to someone with extensive experience can help inform you whether you have your treatment and monitoring, locally and close to home or not, just having that opinion from someone who's highly experienced can help.
So I take it you get referrals for either second opinions or for people to come here for treatment from way outside of central Ohio.
All the time, yeah.
What would be the symptoms of bladder cancer?
The number one symptom of bladder cancer is blood in the urine. If you see blood in the urine, even if it's just tinged with blood, you should see...
So if it's just pink.
Yeah, even if it's just pink, it's worthwhile seeing a urologist. If you're able to see a urologist directly, that's great, or otherwise ask your primary care doctor or practitioner for a referral. The reason it is so important is when you see a urologist because of blood in the urine, generally a couple of things occur. First of all, you'll have some sort of body scan, whether it's an ultrasound or a CT scan of the abdomen and pelvis, just to get a visual sense of what's happening in the urinary tract. The second thing that occurs very often, in almost all cases, is a quick outpatient scope procedure, flexible cystoscopy, where the urologist guides a slender scope through the patient's urethra into the bladder and directly looks at the entire inner surface of the bladder. The good news is, in most of the cases, you don't see a tumor. But if someone sees blood in their urine, 13 to 20% of the time, there actually is a tumor in the bladder. So that's not insignificant, and that is exactly why, if there's visible blood in the urine, you should see a urologist soon. There are some other more subtle symptoms. Sometimes there can be a subtle symptom of like a UTI-like symptom, like burning with urination that seems like or feels like a urinary tract infection, but the urine culture was negative and the antibiotics aren't really helping. Or bladder spasms, sometimes difficulty emptying the bladder can be chalked up to a large prostate. Maybe it's a bladder tumor instead. So there are subtle signs. So if there are other troublesome bladder or urination-related symptoms that aren't getting better quickly, then that should also prompt a urological evaluation too.
Okay. That was a great overview. We're going to take a quick break, and when we come back, we'll dive into treatment and research.
Okay.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Deb, who gave us a great overview on the basics of bladder cancer. So now let's talk about treatment options, which I'm guessing and hoping have advanced a lot in the past decade or so.
They have. Actually, just about 10 years ago, there were relatively few treatment options compared to what we have today, which is, relative wealth of options.
Wow. So run through the different treatment options and sort of how you would determine which one will be best for an individual patient.
Yeah, absolutely. I mean, these are important. The first thing I'll say, by the way, is, for any patient who will come through for consult, at the James, we will think about whether they're eligible for any clinical trials. I mention this because the reason we have so many more treatment options today than we did, only 10 years ago, is because generous patients who were philanthropic in the sense that they wanted to make a gift to their future patient
who they didn't
enrolled
even
in
know.
A clinical trial.
People they didn't even know.
Yeah. Enrolled in a clinical trial, not knowing the outcome, but having some sort of general interest in wanting to advance the field. And lo and behold, that has resulted in several new FDA-approved therapies for patients with bladder cancer today. So For anyone who comes through the doors of the James today with bladder cancer, we'll think about whether they're eligible for clinical trials, and we have clinical trials available for folks with really all stages of bladder cancer, and I'll just make that plug for clinical trials.
So in addition to clinical trials, kind of run through some of the other treatments that you now have available for patients.
Well, it all depends on what type of bladder cancer you have, and a few minutes ago we kind of talked about different types, right? So if you have first of all, if you have some tumor or growth in the bladder that's suspicious for cancer, the first step is to have that diagnosed, and the way that is done is through an outpatient procedure called cystoscopy and transurethral resection of bladder tumor. That's a procedure where the urologist looks inside the patient's bladder with a scope, but this time the patient's actually in the operating room, asleep under anesthesia, and the particular type of scope that's used during the transurethral resection of bladder tumor, abbreviated TURBT, is one that allows the tumor to use an electrosurgical loop or electrical scalpel, so to speak, to basically scoop out the tumor from the inside of the bladder.
So it's almost like a colonoscopy where they're looking at it, they can also remove it at the same time.
That's exactly right. And that's important for a couple of reasons. Number one, it establishes the diagnosis. It will allow the pathologist to look under the microscope and say, okay, I can see that this bladder cancer is low grade or high grade, or I can see that this is non-invasive or invasive. So you can establish a grade and a stage. The other reason that operation or cystoscopy with TURBT is really important is it is often therapeutic. It can be the only treatment a patient needs, particularly for patients with low-grade non-invasive tumors.
Meaning you can remove the whole thing.
Yeah.
Okay.
Yeah, that's the goal. We go into the operating room with the goal of removing the entire tumor whenever possible. And even if the tumor, let's say, is high-grade or beyond stage TA, that initial resection still contributes significantly to a patient's overall treatment outcome. So it's really important. So the first step is really a surgical step, and that's an outpatient procedure, cystoscopy and TURBT. Okay, so now the tumor's been removed, the stage and grade of the bladder cancer has been established. That will often, by the way, prompt some scans, such as a CT scan of the abdomen and pelvis, specifically to look at the urinary tract, with some sort of imaging of the chest, like a chest X-ray or CT
to see if it's spread.
Yeah, exactly, and that establishes whether or not there's concern for metastatic disease. It's uncommon but possible, so we leave no stone unturned. Then it all comes down to, okay, so we've established the stage and the grade and whether it's spread or not. Now let's look at the menu of treatment options available. If someone has a non-invasive bladder cancer, if it's low grade, sometimes you can just monitor it, and there's a specific sort of schedule of how to do that. If someone has a high-grade non-invasive bladder cancer, the historic standard of care is to treat this medically with an immunotherapy in the bladder called BCG. BCG is actually a living attenuated bacteria that stimulates an immune response in the bladder, and that's a type of immunotherapy.
And how do you get that into the bladder?
What happens is a Foley catheter is inserted into the bladder, and then the medicine is dripped into the bladder, and the Foley catheter is removed, and then the person having that treatment for the day essentially tries to hold that medicine in their bladder for a couple of hours before they let it out. So that's one option.
Okay.
Of course, bladder cancer, as I had mentioned earlier, is common. Just how common is it? 80,000 people in the U.S. are diagnosed every year. It's pretty common. So of these new diagnoses, most are non-invasive cases. And so we talked about whether non-invasive cases treated by monitoring alone after TURBT, perhaps BCG immunotherapy, but it is common enough that a bladder cancer might recur after BCG. And this is where a lot of the newly approved medicines that have been generated by clinical trial efforts over the past 10 to 15 years are starting to play an important role in our treatment of patients. So there are newer immunotherapies available for people where the cancer may have come back after BCG. And instead of having to go right to radical cystectomy or surgical removal of the bladder, there are more medical options that can help someone save their bladder.
Okay, and that's immunotherapy.
Generally, yes.
So the BCG,
yeah.
was something that's been around for a while and is effective initially, but there can be a recurrence, and so now there's new immunotherapies that are effective sometimes in that recurrence. And
that's exactly right.
Could there be a point where these new immunotherapies would be the first thing that you would use instead of the BCP?
That's a really insightful point. So that is exactly where the field is headed. So we have seen now that some of the newer immunotherapies can actually help folks with aggressive, non-invasive bladder cancers where the BCG didn't work. And the thought then is, well, wait a minute, some of these immunotherapies, maybe they should be used as the frontline approach. So we're actually evaluating that in clinical studies right now.
And I'm not sure if you're finished with treatments, but it sounds like that leads into your research. That sounds like that's part of your research.
Very much so. So I would say one of the challenges facing patients and their doctors nowadays in the bladder cancer world is that there are multiple treatments. It's actually a good problem to have, but we do not have any good biomarkers available to tell us, well, this individual is going to respond to that therapy, and this individual will respond to that therapy. So there is a little bit of guesswork involved. It's not totally random. I mean, we have a fairly systematic way of thinking about these things, but it doesn't take away what I would say is a very critical knowledge gap that hurts patients, which is there are no known biomarkers available that actually link specific patients and their tumors with specific therapies that are known to work. So that, to me, is a very high priority problem, and that's what my lab is working on.
So you're looking for the biomarkers that will determine which immunotherapy drugs will be most effective against a specific patient's type of bladder cancer.
What my lab is developing is an assay to non-invasively make an assessment of someone's tumor immune infiltrate through the urine.
Explain what an assay is.
An assay is just a test. And,
okay.
Yeah, and so what we've learned is that if you actually take someone's urine, and this, by the way, comes from a research study here at the James that was only made possible by patients who generously volunteered and said, we could study their tumors and urine in our lab. What we realized is that if you look at the urine of someone with bladder cancer, you can spin down that urine and you'll find some immune cells in there. And it turns out the immune cells in the urine are quite similar to the immune cells in that person's tumor. And so we've been studying that because that similarity extends to at least a couple of different, I'll say a few different types of immune cells, CD4 T cells, CD8 T cells, myeloid cells, if someone's immunologically interested. And those are important immune cell populations because they may well bear out to be the ones that are relevant to whether someone will respond to a therapy or not. And so that establishes this concept that you can actually non-invasively measure someone's tumor immune infiltrate,
through the urine,
which is huge because all of a sudden, it takes away the need to have an invasive procedure or surgery to make that same assessment. And so, because of that, what we're doing is pairing our studies of urine into several clinical trials to address exactly what you talked about. Can we now link this measure of immune cells in the urine to outcomes with different types of therapy on clinical trials? So that is so important for patients, and we're working on that right now.
And that would be a big breakthrough.
Yeah.
That would save lives.
Exactly. And
reduce.
Or at the very least,
yeah.
Significantly improve the precision of therapeutic selection. In other words, helping your doctor pick the right medicine for you, or the more effective medicine for you the first time.
And this will not be just done at the James. If knock on wood, you show this and prove this, this will be done at hospitals and cancer hospitals around the world.
That's the idea. That's the big picture goal. Exactly.
So from the James out to the world.
Yeah.
Wow. And it's fascinating that you're able to determine this from urine instead of an invasive biopsy, because other people have talked to a similar sort of process with the circulating tumor DNA for blood cancers and other cancers. So it's just another example of how you're figuring out how to determine the exact type of cancer someone has with less invasive procedures, and even screening them early to determine if they have it.
Yeah. So the concept of circulating tumor DNA, by the way, is also really important for patients with bladder cancer. Then there is cell-free DNA and RNA that might have to do with the tumor in the urine too. And I'll tell you, just last week we had a bladder cancer research group meeting that kind of brought together a number of bladder cancer experts here at the James, and we were just sort of talking about how it would be really interesting but also important to kind of put together all of these measures, whether it's immune cells in the urine, cell-free DNA in the urine, circulating tumor DNA in the blood, and other kind of non-invasive biomarkers, to really understand more in depth than ever has been before what are the dynamics of someone's tumor. And this all speaks to the notion that if we understand things better, we can improve our treatments and improve our therapeutic selection.
Wow, it looks like you have a lot of work ahead of you.
We do. We do.
And let me ask my final question, which ties right into that. I can see you're excited about getting to this work. What motivates you to think of these new things, to create these clinical trials, to do more for your patients?
The motivation is 100%. It comes from my patients, from taking care of patients. I chose to specialize in bladder cancer as a direct result of taking care of patients with bladder cancer when I was a urology resident. I felt that the experiences of patients with bladder cancer overall was something that we as a society and in the research community could and should improve on. And so that was, why I kind of got into this field. As I've joined the bladder cancer community and started contributing to it, that kind of fuel, is self-sustaining. There is so much excitement in terms of the innovations that are happening in the bladder cancer field. And meanwhile, I'm taking care of patients medically and surgically, and they really provide a daily motivation for me because I want to make their lives better. That's what it comes down to.
Well, thank you. Thank you for sharing all this information, and thank you for the way you take care of your patients.
Well, thanks for your time.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.